Excellent. All right, and we're back. So here we go. Next part of the skeletal lecture is on bone physiology, because we've talked about how it grows, intramembranous, endochondral, and once you're lengthening a long bone, how growth continues at the metaphyses. But what we haven't really talked so much about is how an osteoblast actually makes the bone, how the calcification of osteoid tissue actually works. Right? So this process of mineral deposition, let's see, it's a crystallization process in which calcium, phosphate, and other ions are taken from your blood plasma and deposited in bone tissue, mainly as crystals that are called hydroxyapatite. So hydroxyapatite is shown over here. Let's see. This formula, Ca10 PO460H2. That's your hydroxyapatite formula that is going to be making about 85% of your bone matrix. But then there's also this calcium carbonate, CaCO3, which is the same material that helps to make eggshells hard, and small amounts of magnesium and a few other ions that are going to be there, making up the hard ceramic components of your bone. Right? But before you can get the crystals to show up, you have to give something for the crystals to hang on to, and that's the osteoid tissue. Osteoid tissue is primarily just collagen that has been created by the osteoblast and then secreted into the surrounding area. So say that this is your original osteoblast. It secretes collagen in just small amounts all around itself. And those collagen fibers, as they start to accrete and collect with one another, they start forming more and more long fibers, strands. And so it looks almost as if the cell is becoming surrounded by a mass of steel wool. Just lots and lots of thick, closely spaced fibers. Right? Then, the osteoblast in the middle, right, is going to secrete an enzyme. And that enzyme is there to encourage the calcification process. You see, normally in most of your collagenous tissues, there's an inhibitor present. And that inhibitor stops accidental calcification from happening, so we don't have with ectopic ossification and the formation of bones where there shouldn't be bones. But the osteoblast secretes an inhibitor to the inhibitor, and thus allows calcium minerals to start accreting, or precipitate might be the better word, to precipitate onto the osteoid tissue fibers and start growing in thickness and becoming hard and calcified. Right? So that your mass starts to get the calcium collect around it once that enzyme is in place, and it just thickens and adds to it until finally it all becomes bone surrounding that little osteoblast cell that was there at the beginning. It's still there now, it's just we're not calling it an osteoblast anymore. Now it's an osteocyte, trapped within the matrix that it made. And let's not forget that it's not alone. There's going to be lots of neighbors nearby that are going through the same thing. So that one mass of bone around one osteocyte will join with another one, and another one, and another one, another one. And thus you end up with things like long columns of bone or sheets of bone. Just depends on how the osteoblasts were arranged in the first place. Right. But here's the trick though. In order for this calcification to occur, then there must be at least a certain amount of calcium inside of your tissue fluid. Right? And if you're below that minimum amount, then you can't make bone no matter how much osteoid tissue or inhibitor of the inhibitor enzyme is present. There's just not enough to encrust on the surfaces. So this minimum amount of calcium in your tissue fluid is called the solubility product. And you must have blood calcium above the solubility product in order for calcification of osteoid tissue to occur. Right? So the solubility product is actually measured at this value here, right here. Calcium levels must be 9.2 to 10.4 milligrams per deciliter of blood. That's our solubility product. If we're below that, no bone ever gets made. Okay. So let's see. When we are at the solubility product and osteoid tissue is made and the osteoblasts release the inhibitor enzyme, then the first crystals that are going to form create a seed crystal that then attracts more mineral ions until the matrix is thoroughly calcified. Osseous tissue sometimes forms in other organs, and when this happens, it's an abnormal ossification called an ectopic ossification, like an ectopic pregnancy, which means that you have implantation of an embryo someplace other than the uterus where it should be found. Right? In this case, ectopic ossification, you could have bone show up, say, for instance, in your wrist. There's a lot of connective tissue here that is surrounding your carpal bones and the tendons that are helping to move your fingers and the wrist action, all that stuff. Lots and lots of collagen. So sometimes that happens. You end up with an extra bone forming amongst the bones of your wrist. And this is not necessarily a good thing. First of all, it's going to probably reduce the amount of mobility that you have in your wrist because there's another chunk of bone getting in the way of the joint. So ectopic ossification is something we're trying to avoid. And another example, arteriosclerosis. That's not happening at a joint, that's happening inside of a blood vessel. Right? So arteriosclerosis was one example of ectopic ossification and consists of calcification of the arterial walls. A calcified mass in an otherwise soft organ is called a calculus. So it's not just hard math, but it's a hard bony mass. Right? Now, occasionally, if this does happen, we can take care of it ourselves, because we've got cells that are responsible for removing bone from tissue, and these are our osteoclasts. So let me find the osteoclast image here. Alright, so here's what an osteoclast is supposed to look like. Okay? It is a large cell compared to an osteocyte, or for that matter, osteoblast. Let's see, highlight it. Alright, so here is one osteocyte cell inside of the matrix that it made. But here is the entire osteoclast. It's enormous compared to one osteocyte here, or here, or here. But, as I said, it's made up of fused cells and is a multinucleate cell, one of the few that we have besides our skeletal muscle cells. Okay? One osteoclast can carry out the resorption of bone matrix through a couple methods. First of all, it's got this ruffled border right here where it appears to be made up of lots and lots of microvilli, because it is. Right? And that ruffled border is where you have a high surface area that will allow for more rapid secretion of materials. And in this case, the material is hydrochloric acid. Hydrochloric acid will be released along the ruffled border, which faces the bone surface, and then that acid will now dissolve the hydroxyapatite and calcium carbonate minerals. But that would leave behind collagen, because collagen doesn't get dissolved by this stuff, which is why the osteoclast can also make something called acid phosphatase that can break apart or decompose the collagen so that all the matrix goes away. Now, what about the osteocytes? Well, if they're getting exposed to low pH environments and protein-destroying enzymes, then yeah, they're going to die. They're going to die as they as the tissue that they build gets dissolved too. But not to worry. Even though they die, they can get replaced. After all, wherever you have a bone surface, you're going to find a layer of osteogenic cells. We just don't see the osteogenic cells here, but there'll be some here, and there'll be some over here, and just everywhere underneath the periosteum of the bone. So there will always be new cells to make new osteoblasts and to make osteotissue, to replace any bone that may have gotten dissolved by osteoclasts. But this does mean that we have this, not exactly a fight, but this competition that's going on between osteoblasts and osteoclasts, because both of them are active most of the time, constantly dissolving bone, but also depositing bone, according to Wolff's law. We deposit it on areas that need it, and we take it off of places that don't need it until we have an appropriate quantity of bone based on the strain that's being applied there. Okay? So, once again, you need a minimum amount of calcium in order to allow for bone deposition, right? And that minimum amount is your solubility product. Okay? We've got a number of methods of making sure that we've got enough calcium in the body. So let's go back down to here. Right. So a typical human adult body contains about 1.1 grams of calcium. Oh, sorry, no, my apologies. Sorry, 1,100 grams. It's not a point, it's a comma. 1,100 grams of calcium with 99% in the bones. Bone has two major calcium reserves. Part of that reserve is, deep within the bone itself. Right? It's a stable pool of calcium that's incorporated into hydroxyapatite crystals and is not readily exchangeable because it's deep inside. It's in the middle of your compact bone, not close to a surface. The surface areas are the places where your osteoclasts reside. And so that stuff, the stuff that's closer to the osteoclast, that's exchangeable calcium that's easily released in the tissue fluid. Calcium concentration in the blood needs to be at the solubility product, 9.2 to 10.4 milligrams per deciliter. And if you have too little calcium in your blood, then you have a condition that's called hypocalcemia. Right? And this will have to be addressed. Your body will do its best to try to make sure that it brings that calcium levels back up to a normal, non-hypocalcemic state. And the reason for it is more than just bone health. Yeah, if you don't have enough calcium, you can't make new bone. But also, since calcium is a cation with a +2 charge to it, then if you have too little, it's going to affect other electrical systems of the body, in particular nervous tissue and muscle tissue. Hypocalcemia can cause, excessive excitability, like spasms, tremors, even whole seizures, if it were really bad hypocalcemia, and that would happen to your nervous system, to your muscle tissue. It could cause cramps. It could cause muscles to contract and stay contracted. Right? So tremors, spasms, or tetany, also known as prolonged contractions or cramps. So here's another reason why you want to keep your blood calcium stable. Let's see. If you have too much calcium, then you have hypercalcemia. And this kind of affects things in just the opposite direction. If you have too much calcium, then it can cause nerve and muscle cells to become less excitable than normal, so reflexes would be slow, muscle response would be slow, in some cases it could even lead to paralysis if it were really severe. But to make sure that your blood calcium stays as stable as possible, we've got a number of regulatory methods, including 3 different hormones. Okay? And that's going to be a part of this big section right here. The 3 hormones responsible for regulating your blood calcium, including calcitriol, this one here, and then calcitonin, here, and then finally parathyroid hormone here. Right? So calcitriol is what we're going to start with. Okay, calcitriol. Calcitriol is another way of saying vitamin D. We make our own vitamin D, which is unusual compared to most of the other vitamins. We can't typically make vitamin C, or we can't make vitamin B, but we can make vitamin D, provided that you have enough exposure to sunlight. You see, vitamin D is a steroid hormone, and all steroids are derived from cholesterol. So that's how we begin. We start with a cholesterol molecule, shown here, right, that is then allowed to flow through your bloodstream, and eventually, just pretty much by pure luck, makes its way towards the surface of your skin by flowing to those blood vessels that go to your dermis, your superficial dermis. Because remember, epithelial tissue doesn't have any blood vessels in it, but the dermis below it does. And now, ultraviolet radiation is going to be coming down from the sky, from the sun, or well, whatever ultraviolet light you happen to be underneath. And while your skin is meant to absorb a certain amount of UV radiation, it's not meant to stop it entirely. And so the UV radiation that does get past the melanin in your skin now hits those blood vessels that contain this cholesterol molecule, and it bends it, shattering one of these carbon rings, and so it unfolds slightly, and there you go. You now have vitamin D3, or cholecalciferol, which is not functional vitamin D yet, but it's the starting point. It's the right shape now so that cells in the liver can then further convert it to calcidiol, and then the calcidiol goes through the kidney, where it's then converted into calcitriol, and there you go. You now have functional vitamin D. So in the past, I've asked people to say, all right, where is vitamin D from? Saying it's from the skin is a good starting point, and I accept that as a full answer. But if you want to be really specific, it starts its creation in the skin, but then has to be modified in the liver and the kidneys before you actually have the functional vitamin D molecule. Okay? But now, say that you got it, and a person only needs about 15 minutes of sun exposure a day in order to make the required daily quantity of of vitamin D, calcitriol. Once you got it all, then here are the three things it's going to be affecting. Calcitriol is meant to raise your blood calcium. That's kind of one of the key parts of this, raising your blood calcium. And the first way we should approach it is by considering your gut. Your gut has receptors in its walls that are meant to grab hold of calcium ions, bind to them, and then pull them inwards to your bloodstream. Right? Vitamin D has the ability to cause the gut wall to grow more of those receptors, to essentially grow more uniports that will then pull that calcium into your bloodstream faster. Without the vitamin D, some absorption may occur thanks to diffusion, but that might not be enough to get enough calcium into your system. So, if you consume loads of calcium but no vitamin D, you might not be getting as much calcium as you could otherwise, and so it's just going to pass through the rest of your digestive system and out the body. But vitamin D encourages the growth of more receptors and transport proteins in the gut wall, so blood calcium is going to rise. Second, in your kidneys. Your kidneys also have transport proteins in their walls, and their job is to try to make sure that calcium that might be leaving your body through your urine. After all, calcium is a hydrophilic ion, very, very small. It passes out of your blood into your urine and thus leaves your body. If your kidneys are told to grow more of these antipores, to grab the calcium and put it back into the blood, then that means that your blood calcium doesn't decrease as rapidly as it normally would. And that helps to make sure that your blood calcium stays appropriately high. Right? So at the gut, we encourage more absorption. At the kidneys, we reduce the loss of calcium, and both of those things will now help to try to keep your blood calcium stable. Now the third effect, however, is on the bones. Right? Calcium is stored in your bones, in that readily exchangeable portion, and it can be released through the action of osteoclasts. So, if vitamin D is released into your bloodstream, then osteoclasts are going to pick up on that vitamin D, and they're going to increase their activity, thus dissolving bone off of bone surfaces, like spongy bone or the surface of compact bone, which is a little bit counterintuitive. Most people think when they hear about vitamin D, it's something there to strengthen your bones. Healthy bones and teeth you get with vitamin D, but really, it makes sure that your blood calcium is high enough to be above the solubility product, which means that if you had, say, an excess of vitamin D, it could actually lead to the thinning of your bones because it activates osteoclasts to a greater degree and might be going beyond what your osteoblasts can counter. So yeah, vitamin D actually may thin your bones, but only in the case if you are not consuming calcium and your output of calcium is so great that you can't balance it with what's coming in. Then we have to get extra calcium from your bones, and the vitamin D would do that to you. Okay? But that's hormone number one. Vitamin D, or calcitriol, raises blood calcium by preventing its loss from your urine, increasing its uptake from your gut, and also increasing its resorption from bone through increased osteoclast activity. Okay. Then there's number two. Let's see, wipe those clean. Number two is calcitonin. Calcitonin is the only one of the hormones we're going to be talking about right now that is going to be reducing your blood calcium levels. It does so primarily just by acting on osteoblasts and osteoclasts. Osteoclasts are going to have their activity reduced, which means that they're not going to be resorbing it, so the calcium stays on your bone. But it also has an effect on the osteoblasts. Osteoblasts will now increase their activity. They'll make more osteoid tissue, they'll release more of that enzyme that inhibits the inhibition of bone deposition, and the end result is that more bone gets made. And if more bone is being made, then the quantity of calcium in your blood drops downwards. And so you now are no longer suffering from hypercalcemia, and you have thicker bones. This may be due to Wolff's Law. It may be due just because you did have a hypercalcemic condition, in which case your bones may be now unnecessarily thick, but not by much. I mean, it's going to take a long time of bone deposition for you to have any negative effects from it. But key parts to remember: calcitonin drops your blood calcium by reducing osteoclast activity and increasing osteoblast activity, so that you actually add more bone tissue to your bones. Okay? and thus your blood calcium drops. Okay. Third one is parathyroid hormone. Parathyroid hormone is very much like calcitriol in a number of its effects. First of all, it is going to raise blood calcium once more, right? And it has an effect on osteoclasts, where it's going to encourage more bone resorption, and that's something that vitamin D did. Right? It also has an effect on reducing osteoblast activity, so you're not trying to build bone. If you're not building bone, then you're not taking calcium out of the blood. Right? So let's see, third one, more urinary phosphate excretion. Phosphates were one of the ions necessary to make hydroxyapatite crystals. So if phosphates leave your body, then sure, you may have plenty of calcium, but you're missing one of the other key components of making bone matrix. And so, since you prevent hydroxyapatite formation, there's less bone deposition. So that's something that vitamin D doesn't do. Vitamin D didn't have any effect on phosphate levels, but here, parathyroid hormone does cause the kidneys to release more phosphates. And, now this is also a mirror of what vitamin D did, parathyroid hormone will cause less urinary calcium excretion. So it creates those uniports to grab hold of calcium, bring it back into the bloodstream, keep your blood calcium nice and high. Okay. So why have two hormones that are doing almost the same thing? Well, it's not exactly the same thing. There's no effect on the gut here, thanks to parathyroid hormone, which is what you did have with vitamin D, and parathyroid hormone causes more urinary phosphate excretion, which the vitamin D didn't. Okay. But here we go. These are kind of the key components you want to remember about these hormones. Calcitriol raises blood calcium. Calcitonin drops it, and parathyroid hormone raises it once more. Right? Your sources of these hormones. Calcitriol comes from the skin, and then, if you want to add on to it, liver and kidneys too. Calcitonin, I guess I didn't mention this part, comes from your thyroid gland, which is a gland that is wrapped around your trachea and normally makes thyroid hormone, but also has these cells called C cells, or clear cells, that make calcitonin. And the source for parathyroid hormone comes from the parathyroid glands. The prefix para means next to, and the parathyroid glands are actually on the posterior side of your thyroid gland, essentially 4 little dots of glandular tissue on the back of your thyroid gland that are responsible for making parathyroid hormone. But between these three, we now have the main ways that we regulate our blood calcium and make sure that it is above the solubility product, so that when we need to make bone, it will calcify the osteotissue that's made by osteoblasts. Alright, so let's see, what else is important here? Calcitonin, parathyroid hormone. Oh yes, phosphate levels. Phosphate levels also have to be kept in homeostasis, and some of the same hormones are going to be involved in doing this. For example, calcitriol, vitamin D, raises the phosphate level by promoting its absorption from the small intestine. Parathyroid lowers the phosphate level by promoting its excretion through urine. Right? So here, vitamin D, calcitriol, raise blood calcium. Parathyroid hormone also raised blood calcium. But now, if you're talking about phosphates, these two are antagonistic to one another. Parathyroid does raise phosphate levels by promoting absorption from the small intestine, from the gut, just like it did with calcium. But parathyroid hormone is going to encourage the release of phosphates here. Right? So I think I feel it would be less important for you to remember the phosphate effects. I mean, they're still important, but I tend to focus on the calcium effects of these three hormones. Right? And are there any other hormones that are going to affect one's bone growth? Absolutely. You've got growth hormones that are coming out of the pituitary gland. You've got growth hormones that are coming from the gonads, like estrogen or testosterone, whether you're female or male, respectively. And those hormones will have an effect on how rapidly your bone is deposited. An interesting thing about that is that estrogen and testosterone are both growth hormones that are particularly prevalent during puberty, as one is attaining one's adult height. Estrogen is actually a more powerful growth hormone than testosterone, and encourages the approach of adult size sooner, which means that epiphyseal growth plates close off faster. And as a result, the 18-year-old female has usually reached her adult size by that point and is no longer going to lengthen the bones, and so stays kind of short. Well, shorter than your average male, who continues to grow for another 3 or so years afterwards, because the testosterone is not so strong as to cause the closure of the epiphyseal plates as soon. So it is a truism to say that females mature sooner than males, because estrogen is a more powerful growth hormone than testosterone is. But on the other side, the testosterone is now going to lead to males continuing to grow in height, and so consequently tend to have a taller male average than a female average. All right, but I think that'll about do it for this portion of the lecture. One more for this chapter, and that's going to be on bone fracture repair. So for now, call this done, and I'll see you at the next lecture. Bye now.